In the first instance, I'll wish to welcome you all for this session, which is on difficult situations in Phaco emulsification. And I have with me distinguished speakers, Dr. Ramamurthy. As you all know, he's the past president of AIOS and proficient Phaco and refractive and retina surgeon. And he's the promoter and founder for Eye Foundation. Then I have Dr. Kumar Doctor, who runs the Dr. Eye Institute and among the initial pioneers for Phaco, and Dr. Hemlata Gupta, who is from Center for Sight, and Dr. Purender Bhasin will join us pretty soon, and Gaurav Luthra and Shreyas. Well, I'll start my the first talk, which is on the femtolaser-assisted cataract surgery for complex cases. Now, femto is a tool for the routine surgeries, but more so for the challenging cases, and it is in the challenging cases that you are able to find out the basic advantage that one has with the femtolaser-assisted cataract surgery. Now, let me come to first the flax in posterior polar cataract, wherein I ensure that if a person has a posterior polar cataract, I'll push that person into getting a femtolaser-assisted cataract surgery, and this is what we published in the Journal for Cataract and Refractive Surgery, that how would you use the femtolaser to find out whether in posterior polar cataract there is a pre-existing rent or not. And if there is a pre-existing rent, what all you can do with the aid of the imaging system in the femtolaser. Now, what is important is that the images help you see. This is a clear-cut case of a big rent that you have. This is seen on the slit lamp. So this was a big rent that was there, which you should even see on the slit lamp. And you can see that this is the rent which is thrown up on the OCT of the femtolaser. So what is important here is that you have to leave behind an epinuclear cushion so that this particular area does not dehisce, because there is a big dehiscence which is there. So what you can see is that these bubbles we are raising, and as we are raising, we are giving away a particular epinuclear cushion. So this is a 5 millimeter capsulotomy that we have done, and then a nuclear disassembly. See this rent which is there on the table after the femto. This is an integrated optical OCT on the microscope, and you can see that there is a rent which is there. Now, what is important here is how has the femto helped? We have not rotated anything, but there was a pneumodissection, and with the pneumodissection, the entire nucleus was being removed. And you can see that this is what I told you, that we have a thick epinuclear plate. Now, once you had removed the epinuclear plate, you can see gently when you are aspirating, you have been able to aspirate the entire cortex also without breaking the vitreous phase, and you can go ahead and get out with this particular thing. Now, this is just to show you that a slit lamp examination is important for you. This is a rare thing where you see such a huge defect, but this is the integrated microscope. Even the IOL master can give you the image, and you can see that this was the clear-cut epithelial defect that we got on the femto. And therefore, you can see that this blue area is where we did the nucleotomy. Once we did the nucleotomy here, we have left behind a thick epinuclear cushion, and therefore we were able to take it out, the nucleus, without any fall of the nucleus into the vitreous cavity. Now, this is just another case. Again, you can see that here, this is the defect which can clearly be seen, and we are able to actually do the phaco, and we are able to get the whole thing out. Now, when you're looking at a small pupil, you can use a Malugin ring and get back the patient onto the femto machine and go ahead and do a femtolaser even in a small pupil. Now, this is a flax in a small pupil, as you can see, particularly in this particular case. You can go in. This is a Malugin ring which is being put. Once the Malugin ring has been put, you can see that there is a subluxation in this particular case. And you are able to actually do the entire procedure even with the small pupil that you have. Now, this is a toric IOL that we have used in 18-cut RK. The only thing is that these RK incisions are going to have a little effect on the capsulorhexis. So what we do is that when we are doing the capsulotomy, we increase the energy, that energy setting, so that we are able to get a good capsulotomy despite an RK. And the only thing we do is that we don't place an incision, because it is better to do a limbal incision, and we will not be able to do a limbal incision with the femto. So otherwise, the rest of the procedure goes on pretty much the same as in any other case, but you can even do in minor corneal opacities or RK that you have, you can do these procedures. Now, this is a case of post-traumatic cataract, and we have to do, you can see there is sphincteric atrophy. We are just, pupil is dilated. Can you see a subluxation here? The biggest advantage here is that in these particular cases, you are not requiring to have a counter traction or a traction on the capsular axis, which is required in a needle. So a femto, even in the presence of vitreous in the AC, is going to work, and you will get a fantastic capsular axis. You will have a pre-chopped nucleus, and therefore the disturbance which is there, which is likely to be there, is going to be very little. And you can see we can go ahead and put in a lens which is there, and then an endocapsular ring, and do an SFT in this particular case to bring down the pupil, as you can see. So tough situations like these, where there is a subluxation, dilated pupil, etc., can be done. This is a case with an ICL which has caused femtocataract, which has caused a cataract. The important thing in the ICL is that the optic of the ICL is recognized as the pupil. So that you have to see that you have to enlarge it and bring it on. And the second thing is that this blue line often gets confused with the lens, the ICL lens surface. You can see this is the vault, and you can see this is the anterior capsule which has to be cut. So the only important thing is increase the energy, and you can see we are bringing the whole thing into the proper perspective as regards the anterior capsule, increasing the pupil to the size, and you can see we have got a fantastic capsular axis. There is no problem, but I still use trypan blue in all these cases, that if there is any skip area that you might have, you will be able to take it out. So typically, an LRI has also been done in this particular case. These patients are usually very high myopes. At times, you don't get a toric lens. So the LRI in these particular cases can help you in getting a great outcome, even in such cases where you have a cataract in the eyes. You see, this is a 3-piece lens. So this is an odd power sensor lens that we are putting, because the patient had a minus power. Unfortunately, you don't get toric and single-piece lenses for this. If there is a phacomorphic glaucoma, the biggest advantage of femto is that you are working on a closed chamber. You can see that there is a huge swelling of the nucleus which is there. The iris is coming close to the whole thing. We are doing an LRI which is going to be here. And just look here. There you can see it came out like a boom. You never get an extension, or you almost never get an extension of the capsular axis, but always use a trypan blue, because there could be skip areas with the lenticular fluid that is coming out. But working on what you have, the Argentinian flag sign, if you open the chamber, which you have to do if you are doing a manual capsular axis, you will get an extension, but in a closed chamber, you don't get an extension. Now, this is another thing, acute ACG. Can you see this huge lens that is there for this particular patient? And you can see that the lens thickness here is about 5.85 millimeters. So this is going to be a fantastic case where just a removal of the lens, which we did with femto, and a PI that you did, you could see that the chamber falls back and the ACG. So at times, we are very happy to even do a lens extraction without a cataract for recalcitrant cases of angle closure glaucoma, where on anterior you can find a thick nucleus and the cataract like a 5.8 or a 6, and this is the PI that you can see later on. Rock hard cataracts, again, as long as the cataract is not white, you can see that we get a good capsular axis. This is a black cataract, and can you see these bubbles coming out? And you can see that the pre-chopping is effective. So what we do is that we run the laser 3 times in the same meridian. That means that you can get a deeper penetration, and you are able to pre-chop even such black dense cataracts. White cataract will not allow the focusing, and you are able to reduce the amount of energy that is used. So friends, to sum up, I will say that as technology of femtocataract evolves, it finds widespread use in complex cases. And I would say that it's time to take the leap and switch over to the power of femto. The penetration of femto has gone up. In my personal practice, 70 to 80% of my cases I do with femto. And overall, there is a growth of about 15 to 20% like for like in various centers in India. So this is all that I would wish to say, that femto is a tool that helps the most in complex cases. And to conclude, many devices and aids are also there which help develop the cataract surgeon during these complex cases apart from the femto. And the primary aim is to reduce the surgical stress and the time, and to reduce the ultrasound power and to give better outcomes. And each machines come with the pros and cons. The most difficult thing in the femto is to maintain and to buy a femto. But technology is changing at a rapid pace, and the ones that withstand the test of time will survive. And I think femto, which is now 15 to 20 years old, is a technology that is there to stay. Thank you very much for your kind attention. Thank you. Next, I think, Ram. So Dr. Ramamurthy is going to talk about management of deficient capsules. Thank you.
Good morning, and thank you, Dr. Maipal, for having me in this wonderful course. The topic I'm going to be covering is management of the deficient capsule. I think the immediate goals when you have this complication is to extract all of the nucleus, remove the cortex and epinucleus, reducing the amount of drop lens matter to the extent possible, do an adequate anterior vitrectomy, preserve residual capsular support as much as possible, and just in case you feel you can get away with it, in the first step itself, implant an IOL. So I'll be just showing a series of videos just to emphasize these points. This was a fairly straightforward case, I thought, where you can see a reasonably hard nucleus, but otherwise good size rexes, then conventional phaco chopping being done with my normal settings. All the videos are running at 2x speed, so don't bother if it's a little jumpy. I thought everything was under control, but then towards the end of the nucleus fragmentation, what I noticed was there was a, while I was doing the irrigation aspiration, I had created a small rent over there. It's a well circumscribed rent over here, and before I'm removing the irrigation cannula, I'm injecting a dispersive viscoelastic so as to tamponade the anterior vitreous space. That is the area of the rent, and basically there is adequate capsular support peripheral to the area of the rent. So what I'm doing in this case, the patient was to receive a single piece multifocal implant, and that's exactly the lens that goes in, because it's also a toric multifocal, and because I'm confident of the fact that there is some rexis support available. I have not done any anterior vitrectomy in this case because the anterior vitreous space is tamponaded, and though the orientation of the haptics has to be around the area of the rent because there's a capsular support available, as you can see with the digital overlay that will come on towards the end, I'm able to exactly position the lens in the direction where it's meant to be. Obviously, a good idea to always check with Ramstone estate to make sure that there is no vitreous in the anterior chamber. You can see a good rexis overlap, a lens in the bag, a single piece multifocal toric lens with a reasonably large capsular rent. Of course, this is occurred towards the end of the surgery when I was just doing irrigation aspiration. It was a well-confined rent. Obviously, whenever you have to do an anterior vitrectomy, we're all aware of the IA cut and the cut IA mode, and these are the parameters that I use. Now it's a slightly older photograph. Now the maximum cut rate that's available in my machine is 5,000, and that's what I use. Gentle parameters, IOP of 30, which is what I use in almost in all steps of my cases, vacuum and aspiration being also under control. The most important aspect is you use the cut IA mode, that is you cut the vitreous first and then aspirate, and not the IA cut mode. Just in case you want to switch between the two, all you have to do is to, from the cut IA, you go into the irrigation aspiration mode, and then the vitrectomy cutter just starts working like a normal irrigation aspiration cannula. Whenever you have to cut the vitreous, you go on to the cut IA mode using gentle parameters like this. And this is the initial chopping itself I'm doing, and as you can see over here, there's a fairly large rent that's developing over there. Immediate step is to, there's quite a bit of nucleus left over. Dispersely viscoelastic is what goes in, but because that gets retained and that tamponas the anterior vitreous space quite adequately. I'm gently shifting out over all the nucleus matter in the anterior chamber using fairly gentle parameters, just the right amount of energy. I'm going ahead and removing the nucleus matter, repeatedly tamponading the area of the PC rent, and then subsequently my Sinski hook also acts as a to hold back the nucleus in the anterior chamber. Obviously, the patient is going to undergo a good vitreoretinal examination in the immediate postoperative period to make sure there's no lens matter in the AC. But as of now, all the nucleus seems to have been removed, and the rest of the irrigation cannula is also, irrigation aspiration is also completed. Make sure using the Vexel sponge, in case there is no distortion of the rhexis margin or the pupillary margin, that itself tells me that there is no vitreous in the AC. Because initially the patient was to receive a single piece lens. Now I have shifted over three piece lens, I enlarged the rhexis, enlarged the incision, and then subsequently I'm placing a 3-piece lens and creating an optic capture. This is one of the best lenses, the best ways of dealing with whenever you have an adequate PC rent. And I have cases which I have followed up for 20, 25 years after a PC rent with a good 3-piece lens placed with the optic capture with excellent visual outcome which the patient maintains. And another situation, there's a fairly hard cataract. Again, it seemed to be, everything seemed to be under control. I'm staining the capsule and going ahead with the surgery. Once the first heminucleus is removed, I find that there is a significant rent that's developing. Here again is a situation where the anterior vitreous face is not disturbed. So what I'm doing now is to, the first heminucleus is out, but I am going ahead with the second heminucleus. I realize that there is tilting into the vitreous face. So what I'm doing is to bring in the nucleus fragment into the anterior chamber, then introducing viscoelastic and introducing a 3-piece lens in the sulcus. Basically, the lens itself acts as a tamponade. It partitions the vitreous cavity from the anterior chamber so that the propensity for the lens matter to sink into the anterior chamber is significantly diminished. Even in case you are using a single-piece lens, you can place it in the sulcus or in the bag and then subsequently position the lens after the nucleus fragment is removed. Once the lens is there, I am more confident there is less chances of the lens material to slip into the vitreous cavity. And now the irrigation aspiration, that's a vitrectomy which is being done behind the lens. I'm going behind the lens and doing adequate amount of vitrectomy. Always use diluted triamcinolone acetate to ensure that there is no vitreous strands in the anterior chamber. And again, I always do this test where a regular pupil and a regular rhexis tells me there is no vitreous in the anterior chamber. Obviously a difficult issue, but then you have dealt it with the best possible manner. This is just to show you to look at the simple cues that might tell you there could be a vitreous disturbance. Again, everything seemed to be under control and this surgery was proceeding quite smoothly. But as I evacuated the vitreous, the lens quite completely, you can see this simple distortion over here, which is pointed out by the arrow over there. That without any chafing of the iris, this kind of a distortion itself tells me there's something wrong. I'm injecting viscoelastic. I think I can implant a lens in the back, but then I realize there's vitreous in the AC. I just go ahead because the PC is intact. I think it's a capsular dialysis that has occurred. So implant the lens in place, but you can see there's obviously vitreous in the anterior chamber. And because it's a capsular dialysis that's responsible, I introduce an endocapsular ring. Introducing an endocapsular ring into the capsular bag with a single piece lens is always a challenge, and there is a tendency for the lens to get displaced. I reposition it and then subsequently do an adequate anterior vitrectomy. Once again, the lifesaver triamcinolone acetate comes in, and then you can see there's a wick of vitreous that's coming at around this 12 o'clock position. That's essentially through a capsular dialysis with the posterior capsule itself being quite intact. Once I'm able to address it quite adequately with the endocapsular support for the capsular bag, I'm having a lens in the bag. In case you have a soft nucleus and which has dropped in, oftentimes it's asked whether you implant a lens if you have a problem like this. As you can see over here, this is a fairly soft nucleus. And in this case, you can go ahead and implant a 3-piece lens and create a good optic capture after doing an adequate anterior vitrectomy. And then subsequently, your vitreoretinal colleague can deal with the lens matter quite adequately. And that's the three-piece lens that's gone in and the optic capture that has been created. Obviously, you're not going to mess around with the lens material behind, and your colleague is going to deal with it. Just in case you have a hard nucleus fragment, like in this case, which goes in, nowadays with the kind of fragmentome that's available and the kind of technology that's available, our vitreoretinal colleagues are able to deal with these cases quite adequately. But just in case you feel that the patient has to be referred elsewhere and there's going to be a time lag, it might be a good idea not to put the lens in place, because with an intact rhexis, there is a small rhexis runoff over here, just suture up the incision and then go ahead and refer to the vitreoretinal colleague. I think the most important message is not to chase this. As you can see, this is the final video of mine. This is the kind of treatment that a dropped nucleus requires. So obviously, when you're going to chase it with your Vectis or something, they're creating considerable traction on the vitreoretinal, on the pars plana, creating dialysis, etc. And CME is something that's difficult problems to deal with. So when you have, it has gone beyond your limits, better refer it to a VR colleague. Thank you so much for your kind attention.
Thank you very much, Dr. Ramamurthy, for the management of PCRs and deficient. Any comments, any questions before we, yeah, please. Go ahead.
Good morning, sir.
Yeah, we can hear you.
Sir, my question is that how do you explain rent occurring in these cases? You have done everything well. You have removed the lens piece very well.
Please come closer to the mic. No, closer to the mic, just like.
We have done surgery very well. We have take out the lens very well. Then at the time of putting the lens, you find the rent. So how do you explain this rent occurring in this kind of surgery well done?
You mean everything has gone off well while putting the lens, you create a rent?
No, no. You have performed this surgery, you have taken out the lens, and then you find that there is a rent looking at you. So how do you explain rent occurring in these cases?
He's wondering why the rent has occurred.
No, he's one. So basically, you need a good ophthalmologist to check your vision that you missed the rent at that time.
No. I think.
Sometime can there be a capsulocortical adhesion that is taking
but
away
you should be able to visualize. It's just a question that when you have cleared up the entire cortex and the nucleus, that's the time the red glow comes out much better and you're able to visualize it. I don't know if you have to add. You say everything went well according to you, right?
Yes, sir.
Yeah, and then at the end, you visualize the rent.
One video I saw that everything was managed very well. Still there was a rent, and he has to place.
Matlab rent hua kab is your question?
Yeah, how did it happen? Because
no, in the sense that you are quite right. Even in the videos that I showed, there are quite a few times when you feel everything has gone well, and when you are just about to place the lens, you find there is a rent. And like in that one case I showed where there was just a small pupillary peeking, I thought everything was perfect, but then there was a capsular dialysis and vitreous was peeping in. So obviously, any time where there's a imperceptible surge, where maybe your aspiration cannula rubbing on the posterior capsule a little more vigorously than what it should, you can develop a PC red. But the thing is, irrespective of when it has occurred or why it has occurred, you have to deal with it.
no, sir. One problem that I face sometimes, that rent occurred to everyone. Rent occurred to me. I did vitrectomy. I placed the 3-piece. I did the optic capture. And next morning when I do the post-op evaluation, I find the vitreous in the AC. So
See,
how to avoid this situation?
Okay, fine. I think the answer to your question is that once you have put the lens, or maybe there was a smaller rent and the upthrust at that particular time, chamber shallowed and maybe the rent increased, so you are visualizing it better now. It's just a question of visualization. After removing everything and you are visualizing it later, that's about it. I think that's what your question is. So you have to handle it the way it is. Thanks, Ram.
Sir, one question I have.
Yeah.
In the video which you showed the rent occurred before you could complete the Phaco. So you put the IOL scaffold, and you completed. I got that part. You did the scaffold and did the Phaco. But then how do you do the IA, like cortex aspiration, once the IOL is there and a rent is there? Like any tips, like how?
One thing is there, if the vitreous is already in the anterior chamber and it's admixed with the lens material, I don't go for a IOL scaffold. It is when the anterior vitreous face is intact and the lens matter is still there, I go ahead and put, after bringing in the lens, the nucleus fragments at least into the anterior chamber, I go ahead and place the lens. And after that, after doing the Phaco, I go with the vitrectomy, with the aspiration in the anterior chamber, I go with the vitrectomy probe and do an adequate anterior vitrectomy. The same probe itself, as I said, you can switch over to the irrigation aspiration mode and aspirate the whatever cortical matter is there.
Okay, with the same probe, with the vitrectomy.
Yeah.
Okay, thanks.
Thank you very much. We'll move on to Dr. Kumar, doctor, a fantastic proficient surgeon and great teacher at that. He'll be talking about managing the hard nut. Kumar.
Good morning, everybody, and thank you, Maipal, for this opportunity in this fantastic course. Can I have my slides? Thank you. So I'm going to show you a case, and I want an active participation from the audience. So let me show you the right eye and the left eye, okay? So you use any slit lamp. I also have a photographic slit lamp from Topcon, and any slit lamp you try to put light from the front part, it won't penetrate the anterior 1/3 of the nucleus, and you can't see the posterior capsule at all. So anything, any full power, nothing, you could not go beyond this to even see it. So this is one eye. So now I'm going to have active participation from the audience because I'm going to ask questions, and then I'm going to tell you what I really did. So question here is, what will you give him or her, which IOL? Okay, because this is the case you can see, very, very hard cataract. You can see the anterior capsule, and beyond that, it's only the nucleus. You can't see the posterior capsule at all, okay? So will you do an ECC, SICS, ICC, Phaco, Flax, or Phaco only? Anybody from the audience? Quick answer, because I have to finish in 7 minutes. Nobody? Flax. Yeah, these flag guys will talk only flax. Nobody from the panel I'm going to ask. So anybody from the audience, because I did a similar thing in BOA, and the whole panel said SICS. So if someone can wait this long to get a cataract, is not in a hurry to have early visual rehabilitation after surgery. So the next question is, can you refer this to your best neighbor and forget about it and wish them best of luck?
You can refer them to Delhi also. Maybe we are not neighbors. So,
okay.
Kumar, the question here is SICS for people like me who don't know how to do SICS, we'll do ECC.
See, I don't know SICS. I'm good at ECC. I'm sure you must be in the same boat.
Yeah.
I don't think you know how to do SICS.
No, I don't.
It's the same as me. So some of us never learned SICS. We learned ECC, and then we went straight to Phaco. But now the next question is, what did I do? So you can see that it's a completely black cataract. There is absolutely no glow. There is nothing you can do about this. And I'm going to ask you questions again. So let's see what I did. So you can see that I did flax, okay? But you can see there is no glow at all. I mean, this is the hardest cataract I have ever done in my career. And so did Virion, okay, went ahead. Of course, very important, and I think Mahipal mentioned this, when you have a black cataract, like you have a white cataract, and you do flax, it's very, very important to use the dye. The reason being, sometimes you may have some tissue adhesions, or the CCC may not be complete. In that case, even if you increase the energy of the CCC, you may miss it out. So here you can see that I put the dye, and I'm using a viscoelastic. Obviously, you all know it would be viscoat, no financial interest. I remove the bubble, normally use methyl on the cornea, and I use viscoat in the eye. Make your incision, okay? Go ahead and do that. And then gently make sure that your CCC is complete. So I'm gently lifting the CCC and removing it with the help of a forceps. It's like you pinch a handkerchief off from there. And hydrodissection, of course, has to be very, very gentle. Obviously, there is no space. As you saw the clinical picture, that it's a very, very hard cataract. Now I'm going ahead and seeing what I can do next. Now, we have the overlay, and you can see that during phacoemulsification, another trick here is to use a brand new tip. Don't keep autoclaving the tip and use an old tip in a hard cataract. Make sure you remove a brand new tip and use a brand new tip for such cases. So you can see that gently I'm going around doing phacoemulsification. The hardest part normally in the nucleus is the central part. So you make sure you make a little bowl so that you can get a whole grip. And again, use more of viscoelastic. So you can see I'm stopping, putting viscoat, stopping, putting viscoat. Okay, I'm specifically using the word viscoat because there'll be questions at the end of the procedure too. So I'm going around, okay, and then bringing it, and then chopping, going around, chopping. I use a sharp tip chopper, no financial interest again. A different lengths of sharp tip chopper are available in the market. Normally it's 1.25, 1.5, 1.75. Again, I've come out, put methyl on the cornea. That gives me also a little time to breathe and then gets our pulse down besides the pulse of the patient. And I'll tell you why. So I'm going around, now the pupil decides to come down, obviously because it's taking time. Again, put viscoat. Viscoat itself will help you to keep the pupil well dilated throughout the procedure. So you can see that now I'm going around and now I'm getting all the pieces out, one by one, and then again coming out, putting viscoat and going around. So a lot of patience is necessary. Don't get impatient. Carefully, of course, do this. And then going ahead and again removing one piece. And then once the whole pieces are out, you can see that the bag is clear. Once then we go ahead and do IA, that's when we actually get time to breathe. Go ahead and put in a lens. Now you'll see one of the lenses, which I've never used this lens before. This is the first time I'm using this lens. So that was a little funny, I'll tell you the story later. Go ahead and make one more side port. There's no harm in making one more side port to remove the subincisional cortex, which is there below the CCC, which was done with the help of the femto. And then go ahead and put a lens in the bag. So you can see the cornea remains clear, and the lens goes into the bag, and everything is fine. Now, more interesting part here will be the next question here that I'm going to ask all of you. And now the panel can answer this, no harm. How old do you think this patient was? Say that again? 93, okay. Anyone in the panel, how old do you think this patient was?
How old are you?
Patient was older than me.
Oh, he's older than So he said 93? So maybe, yeah.
Yeah, Shreya?
Sir, I had to think before saying that the patient was older than me, so I'm guessing 60.
60, okay. Anybody else wants to say? Okay, so the patient is actually 62, right? That's one part. So not, you'd expect a cataract like that and a patient to be 80. What do you think was the vision in each eye? So you want to see the clinical picture again. This is the right eye, this is the left eye. So what do you think was the vision when the patient came to me? Anybody?
6'9".
6'12", okay.
See, these people normally are high myopes or they are diabetics, and their vision actually keeps on degrading, but they still see. So that's the reason they don't come to you.
Yeah, so the vision was 6'18",
Yeah.
which is correct, and 6'12" in the other eye. What do you think was the profession of this patient?
Jeweler.
Jeweler.
Yeah.
Anybody else? CA or doctor, okay?
Okay, most of the patients that I have done of this kind, they are ministers in the central government.
Ministers in the central government.
Cabinet
okay.
ministers.
So you'll be surprised, he's an operating ophthalmologist. And that will explain many things what I was doing during the surgery. So he's actually operating ophthalmologist, okay? So now serious questions. How much BSS do you think I used? So I used 1.5 bottles. How many viscoelastics do you think I used? Mahipal?
5.
5. अरे तेरे को तो free मिलता है.
हाँ, मेरे
तेरे को
को
तो
free मिलता है. How many did you use?
3.
3, okay.
And I used the Rayner lens. So when I said I've never used this lens before, because the ophthalmologist came with that lens in the hand and said, use this in my eye.
Okay.
And when I was operating, he was actually telling me what to do. So put the viscoelastic. I've used Rayner lenses before, but I've never used this. So he said, put viscoelastic there, and then you inject the lens. And I said, okay, and it all went fine. So what do you think was the first day post-op vision?
Basically, he must be listening to your talks. Vision was 6'6", obviously in Kumar's hand.
Yeah, so that's correct. The patient was very happy. When he called me in the evening, I got nervous. I said, "Kuch dikhta hai kya?" So because you expect SK, etc., etc. He said, "Nahi, dikh raha hai." I said, "Theek hai to fir." And he comes next day and he was 6/9 unaided. He was very happy because he was N6. So I was surprised. I think the Rayner lens does quite well. And luckily, he came back for the other eye to me. Thank you for your attention.
Thank you very much. So any questions, or the take-home message is that you have to be patient with a hard cataract. Nowadays with the new machines, even if you don't have a femto, obviously I would prefer, these are cases where I also showed you a black cataract, and where my fellows or one of my juniors said, sir, we'll do an SICS, and we had actually made the incision, the surgery that I showed. But I said, no, my ego came in. I said, no, I have to do a Phaco. So actually, if you're doing Phaco in the proper plane and using BSS or BSS plus and using Viscort or chondroitin sulfate, I think you do get. The main thing is to break the backbone of the nucleus. That's the main thing that you have to do, and be patient. The fluidic-based machines which you have, you can go to higher vacuums and things like that. You are able to get good results. And it's often when your head lean comes down and you're left with the last piece that you kind of heave, or you're doing an IA, that you tend to get a rent. So just lower down your parameters. Yeah, go ahead.
Yeah. So one question, when you did a capsulotomy with flax, why didn't you further use it for the nucleus division? You did a flax capsulotomy, no?
Even I used it for the nucleus also. But
Okay.
I have the Zimmer. It's like the catalyst. You have to increase your energy for, depending on the grade of the nucleus.
Okay, so you use flax for
Yeah,
the
yeah, yeah.
nucleotomy.
Yeah, yeah.
Okay, it didn't seem as though you'd used it.
Obviously, because it's so hard.
Okay, secondly is
See,
what kind
basically,
of
I
chopper?
don't know whether you were there at that time, but the case that I showed, you could see the air bubbles coming up.
No.
So what that meant is that it had penetrated the bottom. Yeah, go ahead.
Second is what kind of chopper did you use? And also the tip that you used, it was the normal tip, you didn't use a Kelman or a balance tip?
So it's a sharp tip chopper made by Epsilon. It's on my name. It's called the Kumar's chopper. It has different lengths. It's a sharp tip. As far as the tip is concerned, I have a Veritas. So I can't use a bent Kelman tip or anything like that, what you can use on the other systems.
You can have Kelman tip.
No, a bent tip. So I use So I use a normal tip, which is 15 degree or 30 degree, depending on what. I don't use a 45 degree. But important take home again is to make sure you take a brand new tip for hard cataracts.
Thank you very much. So there are three commercial interests. One is to buy the Dr. Kumar Doctor's chopper. The second is to buy Viscort, and the third was to use Rayner Galaxy lens. Okay, over to Purender, who's at Gwalior, again a great surgeon, and one of the maximum number of surgeries that is being done in that region. He'll be talking about posterior polar cataract. Thank you, Purender.
Thank you, sir, everyone. And posterior polar cataract is definitely an enigma for any ordinary or any proficient surgeon. So it is the incidence is from 3 to 5% in 1,000, and bilateral involvement is seen in 65 to 80%. We should think of when you see a case with the PC rent, central PC rent, then you should think that in other eye there might be a posterior polar cataract, because these are bilateral most likely. And the important thing with this posterior polar cataract, which has to be remembered, is that there is a pre-existing defect in the posterior capsule, or the posterior capsule is fragile. So this is the morphology, this is the look of these cataracts, and bullseye or onion ring, what they say. And it predicts the intraoperative behavior. When you see on the slit lamp, that will tell us how this cataract is going to behave during the surgery, whether there will be a pre-existing rent, or rent will occur when you are doing irrigation aspiration or doing the Phaco procedure. So it is challenging because of the weak pre-existing posterior capsular defect, and there is a high chance of posterior capsule rupture. And the PCR rate can be, which has been published, is 0 to 36%, but it can be anything. Even in the experienced hands and everyone, the rent can occur in these cases. And we should plan all these cases, as you saw that 35% you get a PC rent, but we should assume that all these cases are having a weak posterior capsule, so we should presume and perform the surgery by thinking this kind only. So it's not going further. Oh. It's not moving further. So one second. Cancel करूं? So the important thing which we can assess beforehand is by doing ASOCT or pentacam. As you can see, you can make out there is a posterior cone in the pentacam imaging, sham fluke imaging, or there is a kind of a moth-eaten or irregular posterior capsule, as you see on the bottom pictures. These are from our own pictures from our own pentacams. So hydrodelineation is the cornerstone. So the most important thing is fill the chamber with viscoelastic and do the hydrodelineation, which is the cornerstone, which is the most important thing. You never do hydrodissection in these cases. A thick, and this golden ring should be there. Many ways of doing hydrodelineation has been given in the literature, Dr. Vasavda's technique from inside out and others. The only thing what important is to be remembered that there should be a thick posterior the cortex sheet or epinucleus sheet, which will prevent the rent to occur. Now, we should keep low flow, low vacuum parameters, avoid sudden chamber shallowing. So always fill the chamber with the viscoelastic before you remove the irrigation handpiece, and ensure watertight incisions that should match with your instrument, the side port incision. Closed chamber dynamics throughout the surgery. Stability is very important, and nucleotomy, we should not rotate the nucleus fully, just disengage from the epinucleus plate and leave it there, and as far as possible. And lambda and Y techniques are suggested that can be done. But what I do is I remove the central nucleus first and then epinucleus slowly. So posterior epinuclear plate is preserved until the end. And viscodissection or could be done, or you can use the iris spatula and release the adhesions of the epinucleus plate, and you can bring it to the anterior chamber. Cortical aspiration should be done from periphery, and the central part, which is the area of moth-eaten appearance, should never be touched. Even if you see, and maybe you can touch it after you have implanted the lens. So this is the case, young patient, and having a posterior polar cataract. And all these patients, their quality of vision is very poor. So they always come forward for the early cataract surgery. So the hydrodelineation is done, and a band of epinucleus is left over, and then this is a soft cataract. So remove the nucleus, which is soft, and I use the iris spatula to release some the epinucleus sheet from the undersurface of the capsular access rim, and the cortex is aspirated from periphery towards the center, and do not touch the central part and till you have implanted the lens, or rather you can do early IAC capsulotomy in the postoperative period and fill the chamber with viscoelastic, and the lens is placed in the bag. So this is the way it should be done. Another case, slightly more denser nucleus and a typical posterior polar look with the bullseye appearance. Capsular axis is adequate sized. Various types of capsular axis has been suggested. I think the routine capsular axis size is okay with all these cataracts. Oval capsular axis and many other types have been described. And then you chop it as if it is possible, the nucleus, and gently rotate it. Because the speed is more, that's why you see it is 2x, that's why you are seeing it fast, but it has to be done all in a very gentle way. My posterior plaque is still there, and I am releasing with the viscoelastic cannula from the periphery. Never touch, don't ever try to touch the central part of the posterior capsule. So the sheet is pulled out from the periphery towards the center, and some moth-eaten appearance will be visible. Some flecks of PC are on the posterior capsule, bread-eaten kind of bread crumbs kind of things are visible. Don't touch them, because the moment you are going to touch, the lens capsule is very fragile and it is going to break. So the lens is placed inside. This is flax helps us in many ways in these cataracts. Just one last video, and hydrodelineation, similar thing. So this helps us in the nucleus debulking in the center, and central piece is removed with the Phaco, and after this, friends, so sometimes we can land up in the PC rent in these cases. So as has been mentioned by Dr. Ramamurthy, how to manage these cases. Key take-home message is posterior polar cataract surgery demands anticipation, not the reaction, and weakness is the root problem. Strategy matters more than machine settings. Controlled Phaco can achieve excellent outcomes. Respect the capsule and it will respect you back. Thank you.
Thank you very much, Purendra. Any, yeah.
Sir, it is my only clarification.
Yeah.
See, you said PCO. After emulsification, everything is being emulsified. If it is a capsular cataract, definitely it will not be emulsified. It is a cortical cataract, posterior cortical cataract. PCO, capsular, it cannot be emulsified. This is, I request your clarification. Thank you.
This is a posterior polar cataract which involves the posterior capsule mainly and some part of epinucleus, the posterior part of epinucleus. It involves the posterior capsule. You can see various studies are there, various pictures are there which tells us there is a pre-existing weakness in the posterior capsule or there is a dehiscence in extreme cases.
Any treatment from your side for posterior capsular cataract, sir, not
Any
for
precaution?
cortical cataract?
Posterior capsular cataract.
Yeah.
So this has to be differentiated. They are simple. They can be managed by the simple way. But this posterior capsular cataract, posterior polar cataract are different from posterior capsular cataract.
Okay.
Thank you very much. Thanks, Purendra, for an excellent presentation.
Hello.
We go to next young dynamic.
Hello.
Okay.
Any parameter
Please, can
change?
Yeah, fast.
Any femtoparameter in posterior polar cataract?
Parameters in polar cataract.
Yeah, low vacuum setting, low parameters should be used.
So far the flex is concerned.
You're talking about what?
Flex.
Flex or routine, anything.
And
Flex,
posterior
it
safety
always you require less energy in flex.
And
Flags में
posterior safety
parameters.
margin?
See, your question is
Posterior safety
offset
margin,
is on
whether-
visualization. You visualize up to which level the defect is going and you raise it 500 microns above that. आपको defect दिख जाता है उसके ऊपर लेके जाइए. That's about it. Thank you very much. Thank you, Purendra. We are running short of time, so over to Shreyas excellent cataract cornea surgeon, and he'll be talking about Phaco in hazy corneas.
Thank you, sir. So I'll be discussing about Phaco in compromised corneas and hazy corneas as well, and take you all quickly through some common situations initially. So the most common of this being dry eye. And frankly, while dry eye doesn't hamper our cataract surgery per se, it is really the preoperative measurements that it is going to drastically affect. As you can see, this patient had 3 diopters of astigmatism, significant dry eye, was put on lubricant, cyclosporin, a soft course of steroids, and you can see that the astigmatism went away. So make sure that the optical biometer is the first test that you perform on a patient, especially a dry eye patient. A dilating drop, any contact procedure, applanation tonometry can drastically affect the corneal epithelium, punctate erosions, which can affect the quality of the biometry that we do. Going on to more severe cases of dry eye like Sjogren syndrome or SJS in this particular situation, the basic crux of the message is don't rush into the cataract surgery, stabilize the disease, stabilize the ocular surface before you go ahead. Now, this was a patient with Stevens-Johnson syndrome with a keratinized lid margin, and ideally what we must be doing is stabilizing the ocular surface. For that to happen, you need to replace the keratinized lid margin with a mucous membrane graft, and once the surface is stable, then you can go ahead with the cataract surgery. Even in other conditions like rheumatoid arthritis and other secondary Sjogren syndrome, it is important that we use immunosuppressants, stabilize the course of the disease, stabilize the dry eye situation, and then go ahead with the cataract surgery per se. Of course, you have to be a little more cautious. The visibility can be poor. There is some amount of scarring and vascularization, which is common in these Stevens-Johnson syndrome eyes. Tilt the globe away from the area of scar. Try to complete all the chopping maneuvers in the space that is available superiorly, and then go ahead with your emulsification. Generally, we prefer using a 3-piece lens in these situations, and always the tensile strength of the cornea in these situations will be poor, and apply a suture because the chance of wound leak is very high. And like I already showed at the beginning of the case, these traction sutures can then be removed as the speculum cannot be used in these routine cases. Ideally, with the scleral contact lens, these patients do extremely well once the cataract is removed, and they can continue to enjoy a good quality of vision. In keratoconus, very common, very underdiagnosed condition. Whenever you see irregular K readings, Myers not being good, get a topography done. The main thing that we have to decide is whether the patient is going to undergo a toric lens or not. You can optimize the ocular surface by using a topo-guided treatment or by using an intracorneal ring segment, improving the repeatability of your biometry. That is essentially what is going to determine whether you're going with a spherical lens or a toric lens. If you can get repeatable astigmatism, both in terms of magnitude and direction, you can do a toric IOL. But if the patient is a contact lens wearer and would prefer to go back to contact lenses, it's better to put only a spherical lens in, because if you put a toric lens in those situations, you will end up uncovering the astigmatism with the contact lens, and the patient will have to wear glasses on top of it. So always aim for a slightly myopic outcome, and again be prepared for small refractive surprises which need to be dealt with postoperatively. Again, in these post-DAL advanced keratoconus where post-DAL steroid-induced cataract, the cataract surgery per se is easy. Here again the aim is to debulk the amount of ametropia that the patient has. Using a customized toric lens, no financial interest, but these Ultima smart toric lenses which come in very high astigmatic corrections can also be done. The aim is really not emetropia. We are debulking the power. There will still be some residual power which the patient may wear with, in their glasses, but both their uncorrected and best corrected visual acuity improves significantly. Going on to a setting of trauma. Now this is essentially first the corneal tear repair has been done. There is some amount of scarring that you can see here. The cataract is there from the onset of the trauma itself, but it has now become intumescent. It's better to wait till all the sutures are removed and the wound is stable. Expect some deficiency in the anterior and sometimes even in the posterior capsule. Don't do any hydro procedures. Gentle rotation of the lens. Usually these are soft cataracts. You may have some fibrotic membranes which are proceeding from the wound towards the anterior capsule which need to be cut. and then subsequently, once this has been removed, based on the type of support that you can have, you can either have a 3-piece lens or a single-piece lens going into the bag. But these are primarily the timing of surgery, delaying it as much as possible. Even if the cataract is white and intumescent, you always get better biometry once the wound has stabilized, and wait for the suture removal to be completed in most situations. This is a large failed graft, a therapeutic graft which had been done. You can see that the visibility is quite poor. So you can do a temporary detergescence with some glycerol to improve visibility. You can use chandelier illumination. This is just some glycerol being applied to reduce the amount of corneal edema. Once the chandelier illumination is applied, you can see that the visibility improves dramatically. You can then do a safe phaco emulsification. In the bag phaco can be done, and IOL can be placed in the bag. The importance of doing a good phaco in this procedure is essentially because in your subsequent endothelial keratoplasty surgery, if the IOL is stable and you have a in the bag IOL, your subsequent bubble maneuvers become very, very simple. So this is the main reason why you would want to do a safe phaco emulsification. And once this 3-piece lens is placed in the bag, we go ahead with the desec procedure. Air bubble should be as tight as possible. Needless to say, close all the ports and suture them well, and venting incisions can also be prepared because it's a large graft and you will rarely get a very tight fill. Again, in a post-PK situation, you want to protect the corneal endothelium as much as possible, and sometimes the pupil doesn't dilate very well. And very often when you're doing the phaco, if the iris is coming close to the wound, our phaco naturally tends to become a little more anterior. So using the subincisional hook, keeping the the cataract away from your phaco probe, ensuring the phaco probe is as deep as possible into the bag itself, helps in ensuring that you protect the endothelium. Using, of course, viscoadaptive substances will help in protecting the endothelium as well. Again, adherent glaucomas, the main thing is to not do a PK. There's a couple of situations where you're avoiding a transplant. This is a patient who's had an adherent glaucoma from childhood. So they are essentially seeing through the visual axis above the adherent glaucoma. Doing a transplant does not improve their vision in these situations. So essentially, it's now the posterior subcapsular cataract which has compromised the vision. Tilt the globe inferiorly, do small, simple chopping maneuvers, and then the cataract can be removed and IOL can be placed. Another situation, patient with a failed graft in the other eye, vascularized failed graft, a significant dense corneal scar with a brown cataract. Becomes very, very tempting to do a PK with a cataract surgery. But mind you, this is a neurotrophic cornea. If I do a PK, they will have significant post-op healing issues. Patient has high risk of developing a secondary infection and losing this eye, like the first eye, which is now a vascularized failed graft and has just PL vision. So the aim of this is to really just give them ambulatory vision. And all I'm doing here is ensure it's a hard cataract, but tilt the globe into the area where you have visibility, do multiple sub-chopping maneuvers, ensure that the chopping has been completed before you do the emulsification procedures, because if you try to remove the nucleus and you end up damaging the capsule, managing a ZD with poor visibility becomes more difficult. So complete the entire chopping and then go ahead with the emulsification, and you can do a safe surgery. This patient actually ended up having 6/18 vision despite his corneal opacity, and for this one-eyed patient, this is very, very valuable. Thank you so much for your attention. Thank you.
Thank you very much, Shreyas, for an excellent presentation. We go on to Dr.
Sir, any special reason for putting in 3-piece in these kind of cases?
I mean, keeping a 3-piece standby, you can, if the bag is intact, if everything is okay, you can go ahead with a single piece in the bag as well. It's just that keeping a 3-piece, generally I advise 3-piece because you can come across difficulties either in the deficient capsule in the setting of trauma or in these more difficult situations where complications tend to occur. That's about it. But otherwise, yes, if the bag is intact, you can go ahead with a single.
Thank you. Over to Dr. Gaurav Luthra, whom we all know is really a fantastic surgeon based out of Dehradun, Drishti, and he'll be talking about pupil and iris issues, expanders and reconstruction. Over to Gaurav. Thanks.
Thank you so much, Dr. Mahipal sir, for making me part of this course, and very good morning to everyone. I'll try to share a few videos of my surgeries. This is a 22-year-old man who had injury with a wooden stick 2 years back. presented with iris prolapse and a perforation was primarily repaired by another surgeon, and a tissue iris abscission was done, and then it was sutured. So this was the primary repair, and then this patient went on to develop a cataract. It was a rosette kind of a cataract, it's a traumatic cataract, and eventually needed a surgery, but there was a big iris defect, and you can see that there was loss of iris tissue where the abscission had been done, but there was also a big sphincteric tear. So my first instinct was to think about doing a single pass 4-throw pupilloplasty and join these two areas here, and which would have been fairly easy to do, but this would have drawn the pupil a little bit this side. This defect seemed to be a little too big, and it was probably going to need something else. So what we decided to do was, we obviously planned for a cataract surgery, noticed that there was symmetric astigmatism, and we tried to design a ring which would have a prosthetic part to it, and these can be customized, and we got several designs made, trying to see what kind of a design to put there. And when we finally went through with the surgery, we had 3 different rings, one for 180 degrees and another one for about 120 degrees, trying to see what would bridge this defect. So once we started, the cataract part was fairly straightforward. And the cataract was out in a few seconds. It's a soft cataract, and then implanted the lens. It was a toric lens which we implanted. Now there was a dilemma in the mind, because first thing is, these implants, they require a slightly bigger incision than the 2.2 which we are used to, so you have to increase it to about 3.5, otherwise they don't go, and they are brittle and friable. Also, there are concerns about loss of pigment, but I've had a few of these patients over the last 10-15 years now, and most of them have done well. There have been improvements in these. Of course, Morsher makes these implants as well, but they are very, very expensive. So with no financial interest, the care group does do a good job of customizing these. Now, the problem was whether to put this into the bag or put it in the sulcus. That these things don't go into the bag. The bag is not enough to hold these implants. So we eventually decided, and after doing a bit of literature search and finding that they do well in the sulcus as well, we were able to position this to bridge that defect over there, and position it into the sulcus behind the iris at all points. So eventually, patient did well. There was a high-powered toric here, almost 2.5-3 diopters of astigmatism, and the eye trace showed that we had been able to correct astigmatism almost completely. And this patient eventually did well. I think there's one slide missing. I would have shown you the post-op outcome. I think it's kind of left out there for some reason. Anyway, so one way to do it, I usually do a single pass 4-throw pupilloplasty. It does a great job, and especially in these aberrated corneas, you can actually do an excellent job of also minimizing what astigmatism does. And today I might even try, this was done about 2-3 years back, I would have tried to do a single pass 4-throw and make it a pinhole pupilloplasty. Would have worked beautifully well as well. Now this is another patient who came to us. Fellow eye had a very nice trifocal implant done elsewhere. And now this was a very decentered pupil, needed a cataract surgery, somewhat like an ICE syndrome here. And on dilation, it looks much better, but if you saw that the pupil was really pulled to one side, so it's a decentered pupil. So we had to do something to improve the, and this patient obviously wanted a trifocal in the other eye. Now for that, to have the IOL well centered, and then to have the pupil well centered on the trifocal lens was a bit of a challenge. So we decided that we'll go ahead, of course, with the cataract surgery, which is again straightforward here. Rexis was trying to run out. We used the Brian Little's maneuver to pull it in and bring it back, and then managed to clear up the cataract, and then put in a trifocal lens there. Now we did a sphincterotomy on the other side because we wanted to center this pupil basically. So there we've done a controlled kind of a sphincterotomy, and then using the virion, we were trying to see whether the IOL is well centered and the reflexes are there on the middle. And then we are doing a single pass 4-throw pupilloplasty here to bridge that gap and make the pupil smaller. So this works amazingly well. It's very quick. And once that is done, now we have a slightly better pupil and more towards the central area. Then we do another small sphincterotomy to the other side. And eventually we are able to create a pupil which is now fairly well centered. Now on post-op, patient looks well. So you can see that the pupil is now fairly over the central area. And you can see the trifocal lens rings which are fairly well centered. Patient had a great outcome and did well. This was another trauma, firecracker injury. This lady had a big hyphema, eventually improved, but a big iridodialysis to repair. And we had to do both the cataract, and there was a bit of a subluxation in that area as well. So you can get the iris to one side while doing the cataract surgery using the iris hooks. And this patient gave history of having a pterygium surgery done. So the nasal conjunctiva where the big dialysis was a bit scarred. So we didn't want to dissect the conjunctiva in that area. We decided to go with Hoffman pockets. I'll just show you how that is done, and it saves the conjunctiva also for patients who might need glaucoma surgery in the future. It's a great idea to conserve the conjunctiva. So Hoffman pockets in some situations work quite well. So once we put in a CTR to stabilize the bag and then put in the lens. Now once that is done, now we have to come with the task of doing the repair. So you can see that I'm going to create 3 pockets, in the small scratch incision at the limbus, and then dissect with a crescent into the subconjunctival sclera, and then pass the suture. Now this is a learning experience. This is again a surgery done a few years back. As I passed the needle through that iris, I was not holding it. Now that's a big blunder. And I have a big hyphema which has started from the root of the iris, and the iris also seems to have, the dialysis seems to have increased almost by half a clock hour over here. So now I'm going to use the modification which I felt would help us, because you should always either be holding the iris which requires surgery from the area right next to where you're going to pass the suture, or you can bring in a 26 gauge needle and do a railroad technique as I just showed you there. So what you can do is you can just bring this 26 gauge needle right where you want to pass the suture from the opposite side, and then pass the suture, kind of catch the iris where you want to pass the suture right there, and then through the Hoffman pocket and out. So once you've tied the knot under the Hoffman pocket, inside the pocket, you can just trim the suture and your conjunctiva remains absolutely fine. This is the second Hoffman pocket, and so on, a third Hoffman pocket. So 3 sutures passed, and you can see that now I'm ensuring that the iris is not pulled at all, and kind of capturing it into that 26 gauge needle which is ready to receive the suture. So eventually 3 Hoffman pockets do a great job there. And of course there are many ways to deal with this, but this worked well for me. Patient did well over here, and if you, it's got hung, some problem. I think audiovisual team, can you just check? Some problem with the connection.
Yeah. Gaurav, can we?
I think we can, I'm already done. I only had one more
Thank
video.
you
We can
very
go into
much.
discussion if you want. Yeah.
Thank you very much, Dr. Gaurav. And because we are running short of time, and I think the next people are, I will go on to the last talk, and that's by Dr. Hemlata Gupta from Centropocyte. She'll be talking about the third hand pars plana instrumentation for cataract surgery. Over to you, Dr. Hemlata.
Thank you, sir. A very good morning to all of you. So I'll be sharing my experience with the third hand pars plana approach for the anterior segment surgeons. So going via pars plana can be particularly useful in certain situations, like when you have a posterior capsule rent with large cortical matter remaining behind, and especially if the surgeon has placed IOL already in the ciliary sulcus. And in cases of phacomorphic glaucoma where high pressures are there despite IV mannitol, or where the IV mannitol is contraindicated in view of systemic comorbidities. And the surgery in such cases is challenging because of shallow AC and we get inadequate working space. In cases of zonular dialysis or weakness causing acute intraoperative fluid misdirection syndrome, subluxated cataract where the vitreous keeps on prolapsing through the area of zonal dialysis again and again. And additionally, in cases of dense corneal opacities where the conventional microscopic illumination is not sufficient. So I'll be showing some interesting cases, but before that, let's see the instrumentation that is required. Can you increase the volume, please?
Fusion pipe and 3 scleral plugs. Trocar cannula consists of a sharp spear-shaped trocar threaded over which is a round-bodied cannula. In a phakic eye, the cannulas are inserted 4 mm from the limbus The conjunctiva is retracted slightly and the trocar cannula is inserted in a two-step fashion, initially going parallel to the limbus for half its length and then going perpendicular to enter the sclera. The infusion is secured in the infratemporal cannula. And the superior ports used for the vitrectomy cutter are plugged till further use. It is a relatively simple technique which can be mastered easily with little practice.
Let's see some interesting cases. So this was a young boy with traumatic intumescent cataract with pre-existing anterior as well as posterior capsular rupture. So as Dr. Vasavara has already clearly demonstrated in this video that if there is a PCR and vitreous prolapse, and if we do the vitrectomy from behind, vitreous goes behind and there is hardly any further expansion of the posterior capsule rent. But if there is a vitreous, if we do the anterior vitrectomy, the vitreous hydrates and keeps on prolapsing anteriorly, and this may lead to sudden extension of the PCR. So keeping this concept in mind, we managed this a complicated case where the patient had a large anterior as well as posterior capsule rupture. So I'm just removing whatever loose lens matter is there in the anterior chamber. Most of it is already intermixed with the vitreous. You can see that it's difficult to remove the matter, cortical matter from the anterior root now because there's a lot of vitreous in the whole of the area. So here we switch to the pars plana approach. As I have shown, it's very, very simple to put the trocar, and we introduce the cutter, and now my cutter is parallel to the plane of the iris. So I can move it all around without causing any traction on the sclera or indenting. It's just simple movement of the vitreous cutter, and here I'm switching between the cutting and only aspiration positions just by changing the foot switch position. You just do the vitrectomy wherever you feel that now the vitreous is clear, switch to the aspiration mode, do the aspiration, and wherever again the vitreous is there, switch to the cutting mode just by changing the foot switch position. And this way, slowly and slowly, we remove whole of the cortical matter. And you can see there's no repeated vitreous prolapse. Even the last fibers of the cortical matter could be removed very safely, and there's no extension of the anterior as well as posterior capsular rupture. So once this is done, we just remove the last fibers of the cortical matter remaining, and then a 3-piece IOL is safely implanted inside the sulcus. So this reduces the surgical time also. This is a very well-centered IOL. Now this second case was a 86-year-old lady who had phacomorphic glaucoma, and the pressures are not coming down despite intravenous mannitol. So again we use the same approach, but here because we are not able to see anything, it's just a blind procedure. So we are not doing complete vitrectomies, just the whatever vitreous comes out, that is sufficient to instantly deepen the anterior chamber so that we get adequate space to do the capsular rhexis. So once the rhexis is done, we proceed with the chopping. Many of these cases have zonular weakness that is pre-existing, and when we are doing the phacoemulsification, sometimes the fluid migrates behind and it increases the intraoperative pressure like it's happening right now. So once that is there, you can see the iris prolapsing, the eyeball is tense. So at this stage, again, you just need to remove a little bit of the fluid that is coming out from the port. Just remove the plug, let the fluid come out, and this instantly again deepens the anterior chamber. So this prevents many complications that can happen at this stage. It makes the surgery really simple. We put the implant the lens inside the capsular bag, and we just pull it out. There's no suture required. It's a self-sealing wound. This is another case where the patient had more than 180 degree of subluxation. So here, when I entered with the side port, there's a sudden prolapse of the vitreous. So we do limited dry vitrectomy, where we remove the vitreous in the area of zonular dialysis. I'm just putting triamcinolone so that we don't touch the posterior capsule accidentally. So it's just clearing the vitreous, whatever is there in the area of zonal dialysis. Then I proceed with the removal of the capsular cap that is already cut by the femtosecond laser. Secure this capsular tension ring in position that stabilizes the capsular bag. Now, doing lens fragmentation is not very difficult. The cataract is not very hard in this case. And the femto has already fragmented, so it was easy to emulsify all the pieces one by one. So you can see that the bag is tremulous, but still the surgery, there's no vitreous prolapse intraoperative. So we remove the epinucleus. The removal of the cortical matter can be a bit tedious because of the CTR ring in situ, but you just need to pull it tangentially to remove the cortical matter one by one. Once you take the IA out, you just fill the capsular bag with the viscoelastic and then implant the 3-piece intraocular lens inside the capsular bag. Then we again remove the plug and do a little bit more vitrectomy. Excessive vitrectomy is also not to be done. That can make the capsular bag shaky. So this is the post-op picture. Well-centered IOL, clear cornea. The patient is doing very well. And Dr. Shreyas has already shown beautiful cases with chandelier. So this is one of the cases where we use chandelier illumination. You can see that how dense the corneal opacity is. With the conventional microscope, it's very, very difficult to do such cases. With chandelier, it gives a very good red glow. So we can do capsulorhexis under direct visualization, and the main advantage is you get very good depth perception. So chopping becomes very easy when you have chandelier in place. So all these steps, the chopping and the IA, you get a very good red glow so that you don't accidentally touch the anterior or posterior capsule. So here we complete the surgery. So going via pars plana can significantly enhance the safety and efficiency in such complex anterior segment surgeries. So the key point is understanding the instrumentation, and with a little practice, you can minimize the chances of re-intervention significantly. Thank you so much.
Thank you very much, Dr. Partha, for an excellent talk. Next session, who's chairing the next? Partha, aajo. I think we can discuss it separately. Thank you all these speakers for this thing, and thank you very much for the audience for coming for the course. Thank you. 1 minute. Ram, can you come for a photograph?